Hello, my name is Pyeritz. I'm one of the original members of GenTAC, and so I'm delighted to have been asked to give a presentation at this very important and useful symposium. I'm a medical geneticist, have been for 40 years, and have taken care of literally hundreds of people with thoracic aortic disease, problems with aortic valves, the heart muscle of the aorta, and it's been very ironic that over the past few years, I was diagnosed as having an aortic problem. So rather than talking about my many interactions with other patients, I'd like to spend a few moments talking about my own experiences, a little bit of the history, some of the outcomes, but perhaps more importantly, my understanding of what take-home messages might be for individuals who are going through what I went through. So let me begin by talking about the underlying condition that affected me, which is the most common cause of thoracic aortic aneurysm, which is the bicuspid aortic valve. Many of you know that, but up to 1% of all of us walking around on the planet have a bicuspid aortic valve. Many folks don't know that, and indeed I didn't know it until relatively recently. But in association with the bicuspid valve, and there at the bottom you see what the bicuspid valve is, it has two cusps rather than the normal three. Not only do you have that valve abnormality, which can lead to all sorts of problems in and of itself, but also enlargement of the ascending aorta and perhaps a constriction of the descending aorta called a coarctation. Interestingly, the region of the ascending aorta that is enlarged is the mid portion and not the lower portion called the sinuses of Valsalva or the aortic root. It's the aortic root that is enlarged in a number of other conditions that affect the thoracic aorta, such as Marfan syndrome. But what the take-home messages are for individuals with bicuspid aortic valve are somewhat different than for an individual with Marfan syndrome or many of the other hereditary causes of thoracic aortic disease. So here's a case report, and I won't keep you in suspense because it is about me. When I was 63 years old, I was being evaluated by my regular physician for a routine visit. And for the first time, he heard an aortic murmur, which was both its systole, consistent with ejection. Systolic ejection murmurs are consistent with aortic stenosis, and a diastolic murmur consistent with aortic regurgitation. And since he's a very bright guy, someone I've trusted for 15 years, he suspected that I had a bicuspid valve and referred me for the diagnostic test that's most important, which is a transthoracic echocardiogram. This study indeed confirmed that I had a bicuspid aortic valve, but also that the mid portion of my ascending aorta was somewhat dilated at a diameter of 39 millimeters. And the very first portion, the aortic root, was indeed normal. So the valve itself was constricted and had a gradient initially of 28/46, and that increased to 32/56 over the course of 3 years. The aortic valve area decreased, and the degree of aortic stenosis or constriction increased. The degree of leakage didn't change. The amount of calcification in the valve itself was extreme. The heart muscle was struggling more and more to pump out the blood, and the size of the aorta hadn't changed. Here's an actual CT scan showing the mid portion of the ascending aorta in 2015, measuring about 39 millimeters in both directions. And here's a lateral view showing that the aortic valve is heavily calcified. So my actual history is interesting because I had had some increased breathlessness, and because the gradient had increased, I went to see my cardiothoracic surgeon, Dr. Joseph Bavaria, at the Hospital of the University of Pennsylvania. And between the two of us, depending more on him than on me, we decided it was time to replace the aortic valve. And given my age, it wasn't necessary to put in a mechanical valve, but rather what's called a bioprosthetic valve, in my case made out of bovine pericardium, which is expected to last at least 15 years, if not longer, with the newer models that are out. Between the two of us, we also agreed that I did not need at this point to have an aortic graft put in to deal with the mildly enlarged portion of my ascending aorta. So I underwent surgery in December of 2015, and here's the specimen of my aortic valve that shows, first of all, it doesn't look anything like an aortic valve because it was so abnormal at that point, and it was heavily calcified. After 3 hours, here I am in the intensive care unit. I was discharged after 4 days, and after 6 days, you see my picture there with a normal mid-sternal scar that's healing well. So everything went very well. I couldn't have been happier. And more importantly, my surgeon, Dr. Bavaria, couldn't have been happier. And this is one of the take-home messages that I'll leave with you, and that is, first of all, choose the very best surgeon available. And because I've worked with Dr. Bavaria at that point up to 15 years and now 20 years, I knew that he was one of the best in the world. So I had no problems whatsoever asking him if he would care for me. And in fact, here he is with me. I'm in the middle. And there's Dr. Bavaria with his associate, Rita, at an aortic symposium just a year or so ago. So we're all very happy with my outcome at that point. So here's another take-home message, that if you have a bicuspid aortic valve, it may be clinically silent for many, many years. In fact, I was an athlete, not bragging about it, but I finished 30 marathons, was a nationally ranked masters triathlete, and never had any symptoms whatsoever up until the time that my primary care physician heard the murmur. So simply because you don't have symptoms doesn't mean you couldn't possibly have a bicuspid aortic valve. And that emphasizes the point that people are born with bicuspid aortic valves, so it's congenital, but the symptoms can be late onset, even in mid-adulthood. The rapidity with which the abnormality of the valve, both in terms of constriction and leakage, progress is probably correlated with the amount of calcification that's present. Not that everybody has calcification, but I sure did. And moreover, the severity and progression of the aneurysm of the ascending aorta, if indeed someone has enlargement of the ascending aorta, itself may not correlate with the degree of leakage or constriction of the aortic valve. And in fact, there are people who have what we would call a normal bicuspid valve, it's not misbehaving in any way, who nonetheless have an aneurysm of the ascending aorta. So the question is when to repair the enlargement of the ascending aorta. So when you're my age, then the choice generally is to wait and see if there's further progression. If you're younger, first of all, you may need a mechanical valve, something that would last your lifetime. And then it would be considered whether and when to replace the ascending aorta. In my case, if I'm fortunate enough to live longer than my bovine pericardial valve lasts, I'm reassured that another valve can be placed inside using a catheter and without needing another cardiac operation. One of the most important lessons that I think I've learned is that every physician, or every healthcare professional for that matter, should at some time in his or her life be a patient. That doesn't mean that I'm wishing ill effects on individuals, but it's very instructive and helpful for those of us who care for patients to be able to have placed ourselves willingly or unwillingly in the shoes of a patient, because I think we can relate much better in all of our encounters going forward. So because about 15 to 20% of people with a bicuspid aortic valve have a family history, what should I do for my family because of my finding of a bicuspid valve? Well, unfortunately, there aren't any genetic tests that can be reliably used today to simply see whether my two daughters or my brother are at risk for having a bicuspid valve. So in the best case, I suggested that they undergo an echocardiogram themselves to see if they had a bicuspid valve. And fortunately, all were normal. So I'm the only one in my family who's been affected by a bicuspid valve. So my last follow-up was last year, about 9 months ago. At that time, this artificial valve was functioning perfectly normally. The ascending aorta had enlarged slightly to 42 millimeters, and that was mildly disturbing, but it's going to be something we follow every December. So as I get closer to December of this year, I get a little more stressed just wondering what the echocardiogram is going to show. I'm hopeful that the valve will function normally. I actually listen to the valve occasionally and I don't hear anything abnormal, so I'm reassured to that extent. But I can't detect myself whether the ascending aorta has enlarged at all. So that will depend entirely on what the echocardiogram shows. And so that in it is the most stressful aspect of things. And this I term and have termed for 40 years in my patients what is the Damocles effect. Some of you may remember the ancient king who would invite people to banquets, and if there was a individual with whom he was in conflict, he would seat that individual at the banquet table with a sword hanging over his head. And of course, the individual was never sure when the sword was going to land, if indeed it was. And that's true for, well, virtually anybody who's got a chronic condition, people with cancer, people with abdominal problems and so forth and so on, that's life-threatening. But it's invariably true for anyone who has an aortic aneurysm, wondering, first of all, is it going to tear? Is it going to dissect? Or when will I need to have it fixed, which is, again, not a minor procedure. So firsthand, I'm experiencing what I've always explained to my patients is the Damocles effect. So I want to emphasize another point, and that is that even in the best hospitals, and the hospital of the University of Pennsylvania is one of the top 15 in the country, things can go awry without being planned. So for example, I had a very brief episode of abnormal heart rhythm. It ended, but the junior physicians caring for me said, oh no, you need to have this drug given to you. We need to make an incision in your arm, put a long catheter in, et cetera, et cetera. So that was done. And when my senior physicians came around, they said, oh my heavens, why were they doing this to you? So I'm not saying that anybody else should understand why things are being done to them, but certainly you should ask. And if I hadn't been sedated, I probably would have asked myself. And you are dependent at a time like this, and that gives you a certain perspective on life. How important it is to be dependent on other people. In my case, my wife, Jane, was the most crucial individual to be dependent upon, and I am forever grateful for that. There's no question that cardiac surgery and incision in your breastbone is painful. It is debilitating to a certain extent, and requires physical therapy. But in my case, having had surgery in December, I was able to get back on the golf course in the spring with no ill effects, and to play and enjoy it. The one final observation is that when you do turn 70 years old, like I have just done, you don't have to retire, but you can run for president. So that's something I'm keeping on my radar screen. So here's another example that I'll share with you of a male who's only 2 months older than I am, very healthy, an athlete, found to have a new murmur, a bicuspid valve, and he underwent an aortic valve replacement as well. Had some complications, had to have it redone, but nonetheless, I felt a certain symbiosis with him, given that we have been through exactly the same thing. And in case you don't understand who this is, that's not me. That's Arnold Schwarzenegger, who is doing very nicely after his bicuspid aortic valve replacement. So thank you very much. It's been my pleasure to share these reminiscences with you. And if there's any way that you can ask me questions at any point in the future, I'll be very happy to try to respond. Thank you.